We are going live in 3, 2, 1. We are live now.
Okay, Dr. Vishal.
Good evening, everybody. Myself, Dr. Vishal Dave, Medical Advisor, Intas Pharmaceuticals. On behalf of Intas Pharmaceuticals, I welcome you all for this expert talk on managing thin endometrium, what we should know, by Dr. Jatin Shah. For moderating this session, I would like to welcome Dr. Aruna Ashok. Dr. Aruna Ashok has 17 years of experience in field of fertility, gynecology, and obstetrics. She is a speaker at international conferences and presented papers. She is guide for fellowship course in reproductive medicine. She is executive committee member of TAPISAR and advisory committee member of OXI. She is also member of ISAR, ASHRAE, IFS, and IAG. Now, I would like to hand over the session to Dr. Aruna Ashok. Over to you, madam.
Yes. A very good evening to one and all. I take immense pleasure to welcome one of the very dignified star doctor who we all look up to, sir. I'm very happy to introduce you. Yes, can you share the slide of sir? Or I can do it.
Ma'am, can you see a green button at the top, bottom at your screen, called as share?
Yeah, no, you wanted me to share. I thought you were going to share. Yes, 1 minute. Yes. I can, yeah, I don't think so. I should share it. Yes, I'm sharing it. Yes, 1 minute. Yet, are you able to see the slide?
Yeah. Yes, ma'am. Can you please put it in full screen?
Yes.
Good to go, ma'am.
Yes. We welcome you, sir, with lots of happiness. You are Sir Dr. Jatin Shah. We all know about him. He's a specialist in assisted reproduction from 1991 to 20 as of now. And he is a gold medalist from Mumbai University, director, Mumbai Fertility Clinic and IVF Center, established more than 20,000 IVF successful pregnancies over the past 30 years, helped establish the first IVF and ICSI pregnancies in UP and Kerala. So he has lots of connection with all over the India. Co-authored textbook Photographic Atlas of Gynecology and Obstetrics, Obstetric Techniques, awarded for the best paper presentation in National Foxy Congress. Young Personality of the Year 2003, pioneered the setting up of IVF centers in Cochin, Agra, Madurai, Erode, Chennai. More than 5,500 national and international presentation guest lectures. He's a founder member of Aspire. Over to you, sir. We are all looking up to you for your presentation.
Thank you so much, dear Dr. Aruna. Dearest Lay, Vishal, am I audible?
Very clear.
Okay. So thank you so much. It's really a pleasure to be here today. And I'm glad to hear that on a Friday evening at 5 o'clock, we have close to 300 people online. And that's really wonderful. I'm sure it's the topic which really attracts everyone, because I'm sure all of you agree that there's nothing more frustrating in an IVF practice than to have perfectly evaluated an infertile couple, then selected the best stimulation protocol, given real hardcore attention to their follicle monitoring and picking up and triggering at the right time, trying to get the best number of metaphase to oocytes and top quality embryos, and then finding that at the culmination, when you are about to do a good embryo transfer, you are faced with an endometrium, which is really thin. And what do we mean by thin and how frequently does it occur? And we all know that when we see that endometrium of 6 mm or 7 mm, we know that, oh my God, here goes one more IVF pregnancy. So the incidence as per the Canadian ART database for fresh transfer cycles around 12%, 14% for FET cycles. Another retrospective cohort studies found an incidence between 5 and 38%. And so it's pretty common. And of course, there are some tertiary clinics like ours, where we only handle mainly failed IVF patients. Maybe the incidence is even as high as 20 or 30% of the total IVF crowd. What exactly defines a thin endometrium? And here there was a lot of controversy. There were a lot of papers which said that 6 mm or less, then it was 7 mm or less, and 8 mm or less. But I'm sure all of you would agree that anything less than equal to 7 is definitely a thin endometrium. I would even consider 7 to 8 not very ideal. And of course, the best would be something between 9 and 13 or 14 millimeters diameter. Also, very often, I'm sure all of you encounter that you can't get and measure the perfect thickness because of the presence of maybe polyps, or maybe an isthmosele, or maybe there is an Asherman syndrome, or maybe you have a large fibroid, or even adenomyosis with total distortion of the endometrial myometrial junctional zone, and that makes it difficult to accurately measure thickness. How despondent should we get? If you look at this wonderful study of 40,000 cycles, 2022, you would be surprised to see that if the embryo quality is good, even between 5 to 6 millimeters thickness as per this study, you still manage a live birth rate of about 20%. Between 6 and 7, you are still at 27%. 7 to 8, you are at about 31%. But the normal regular pregnancy rates are always above 8 millimeters. And contrary to what we thought, that if it goes above 13 or 14, it's not too good, this study tends to disagree, and so do some other studies, which I'll show you subsequently, that even at 14 or 15, you don't need to cancel the cycle. You can still expect excellent live birth rates in the range of 40 to 50%. What about miscarriages and ectopic pregnancies? Is there any connection between a thin endometrium and the occurrence of miscarriages and ectopics? Yes, there is. You can see less than 8 millimeters, you will see the clinical pregnancy rate will be definitely low, as we all expect. But there is a higher incidence of spontaneous miscarriage. From 20, it goes up to 27%. And anything below 8 or 9 millimeters will also have a doubling of the ectopic pregnancy rate from 2% to about 4%, as shown in this large retrospective analysis of more than 10,000 patients by Yuan in 2016. The first take-home message for all of you today is to follow this new classification system for endometrium. I think it's now pretty ancient that we just talk about the thickness, 7 mm, 8 mm, 6 mm. There are a lot of other things that you need to consider when you evaluate the endometrium. So very important slide, and it's just come from Ricardo Ash last year, that not only do you look at the thickness, that is what we are also used to doing, but you look at the thickness of the outer hyperechoic external layer. So this is the one hyperechoic external layer, that is the other hyperechoic external layer. And together, if they measure more than 50% of the total endometrial thickness, then you have the most ideal endometrium. So you will see here that, okay, this is more than 7 mm, and you have very nice and thick outer layers, external layers. Here also you have 8 mm, but you have thin external hyperechoic layers. Here, of course, you have less than 7 millimeter total thickness. And here you see a homogeneous non-triple line endometrium. So these are the 4 categories or 5 categories of endometriums which you need to differentiate so that you can predict and prognosticate that what is going to be the success rate for this particular patient. So in clinical practice, you would grade them as 1 if you see a trilaminar endometrium, and 2 if it is a homogeneous endometrium. Then if the thickness is more than equal to 7, she falls under A. If the thickness is less than 7 millimeters, she falls into B. External hyperechoic areas measured together, if they constitute more than 50% of the entire endometrial thickness, it is alpha. As you can see here, you have a 10 millimeter endometrium, very thick hyperechoic outer layers. This falls under alpha. And if it is less than 50%, then it falls under beta. As you can see here, you have very thin hyperechoic outer areas. So even with a thick endometrium, you still don't have the optimal outcome. Now, how do you prognostic pregnancy rates from this? And this is what the study clearly showed, that 1A alpha, of course, is expected to do the best. So you can expect pregnancy rates of as high as 74, 75% if you have a top quality blastocyst or embryos. But what is really surprising, that even in the thin endometrium group, that is less than 7 millimeters, if alpha is present, that means the external hyperechoic areas are thick, still the pregnancy rate is going to be very high at 50 or 48%. So this is how you can predict, not just by cancelling the cycle at 6.5 or 7 millimeters, but if at 7 mm you find that she falls under alpha and not beta, you need not cancel embryo transfer, and you can still go ahead and expect a good pregnancy rate. Of course, as expected, 1A beta and 1B beta don't do so well. And that is where we need to focus our attention on how to go about treating them, how to go about doing better in the next cycle and getting a better endometrium for them. So individuals falling under 1A alpha and 1B alpha have the higher pregnancy rates, and this hints at a potential role which is played by the thickness of the external layers in augmenting endometrial receptivity. What about etiology? There are so many etiological factors of thin endometrium. We all know acute or chronic infections, genital cocks being quite common, fibrosis, shrinkage of the uterine cavity. Even after a complete course of AKT, it is very difficult for that endometrium to regenerate. Surgical, especially vigorous curetages or retained products and repeat DNCs are one of the commonest causes. Hysteroscopic myomectomy, polypectomy, or a lap myomectomy where the cavity is opened or a suture has gone inadvertently through the cavity, all could be reasons for thin endometrium. Now, there is more and more emphasis also on a thin endometrium being associated with maybe its use of copper T or something like that. And medical, clomiphene cited, of course, we are all familiar that the anti-estrogenic effect will cause a thin endometrium. There are also some studies show that prolonged OCPL administration for say 5 to 10 years could sometimes cause a thinning of the endometrium. And of course, you have various idiopathic reasons where we still don't know the reason. There is no infection, there's no history of surgery, and yet we find that functionally the endometrium is just not proper. So when we move on to treatment options, remember that you are flooded with all these add-ons: high dose estrogen, vaginal estrogen, transdermal estrogen, intrauterine HCG, subcute HCG, use tamoxifen, use low dose aspirin, use pentoxifylline, intrauterine GCSF, PRP, hysteroscopy and endometrial scratching, probiotics, agonists, and so on. So how do you actually go about treating the thin endometrium? The best way to do this is categorize the manipulations as per what is the physiology of behind their use. So hysteroscopy, of course, when you are suspecting a surgical problem such as intrauterine adhesions, hysteroscopy would definitely be the first. Also, to perform a subendometrial injection of PRP or stem cells, you would need to do the hysteroscopy. Second is using hormonal manipulation. And here we have high dose estrogen. We have HCG injections given in the proliferative phase of the endometrial development. And you have the use of mid-luteal GnRH agonist to give boosts of estrogen and progesterone in the luteal phase. The third, improving endometrial perfusion. And here we have all our vasodilators, L-arginine, nitroglycerin, sildenafil, which of course is our favorite, aspirin, pentoxifylline, and vitamin E. And finally, we will discuss newer modalities such as intrauterine instillation of GCSF. What is the role of autologous PRP, intrauterine or subendometrial? And finally, before I end, I will show you something new, which is really exciting, which most of you endoscopic surgeons can really pick it up and do some kind of benefit to these patients before we finally end up with a surrogacy program, which with the new legal scenario we know is pretty difficult to do. And that is one more reason why we need to focus on appropriate treatment of the thin endometrium, because surrogacy is no longer as easy as it used to be. How important is hysteroscopy? Clearly shown by Garcia and Velasco in 2016, where they showed that the only add-on, the only treatment modality which has a lot of evidence and which is of definitely high benefit is hysteroscopy. You can see hysteroscopy is the only one which has a green dot. Most of the others at that time in 2016, we didn't have enough of follow-up research and papers on PRPs and so on. Intrauterine PRP, GCSF, nitroglycerin, L-arginine, vitamin E were all yet considered to have be either unclear effect or did not have any benefit as per the available literature at that time. So which are the cases you would definitely post for a hysteroscopy? Of course, we know if you see a thin endometrial echo throughout or in the lower half of the cavity, if you see fluid in the cavity, you see multiple fluid-filled cavities, or you see fluid trapped in a cavity, 3D ultrasound plays a very important role here. You don't really need MRIs for diagnosing intrauterine adhesions. You can see here clearly, you can see this lateral thickening and indentation showing that the lateral walls probably have some adhesions. And here you can see a large central band subsequently, which is then confirmed on hysteroscopy and also corrected. So a good TVS ultrasound and 3D ultrasound can pick up almost all cases of intrauterine adhesions, which would definitely need a hysteroscopy in the first place. Any other patient also who has a thin endometrium, even in the absence of all these findings, I would definitely do a hysteroscopy to make sure that I'm not missing out on a treatable cause. Besides hysteroscopy, what is new? I'm sure all of you do your hysteroscopies, endoscopic surgeries better than me. So I don't need to go into whether you should use scissors or cautery and which are the pros and cons of both. But how do you prevent recurrence of adhesions? Newer techniques which we have, if you don't want to do a hysteroscopy repeatedly, intrauterine balloon therapy, it's just an ultrasound guided treatment. All you need to do is just fill up the balloon of a Foley's catheter with 4 to 5 ml of fluid under ultrasound guidance, introduce into the cavity and try to dilate the uterine cavity. And some studies have shown that yes, the cavity does open up. Here you can see before and after. After with 5 ml of balloon dilatation done for multiple occasions, maybe 2 or 3 times over a cycle, and maybe you'll be able to improve the cavity size. But a century later, since Asherman syndrome was known, again, I repeat that intrauterine adhesion reformation remains one of the most difficult challenges that we face in management. Of course, we do relook hysteroscopies and relook hysteroscopies, but finally, do we really achieve a perfect cavity? So between the two, given a choice, I always prefer to put a Foley's balloon after a good hysteroscopic adhesiolysis rather than just putting in a IUCD. I think IUCD is just for our psychological satisfaction that we put in something, but no IUCD can actually cover the entire surfaces of the anterior and posterior endometrial linings. And therefore, a balloon for 2 or 3 days, 48 to 72 hours, definitely. And you can see studies have shown in favor of balloon rather than just putting an IUCD. So also anti-adhesive gels are better than not doing anything. And a very interesting study recently, especially in mild to moderate cases where you want a good outcome, is to do intermittent intrauterine balloon therapy in combination with a good hysteroscopic adhesiolysis. So what does it mean? In the study group, they did the hysteroscopic adhesiolysis, of course, in both the groups. In the study group, after 2 weeks, they do intrauterine balloon dilatation, as I showed you earlier with the Foley's balloon. At 4 weeks, they do a second look hysteroscopy, again release some adhesions if they are there. At 6 weeks, again they do the intrauterine balloon dilatation. And at 8 weeks, they do the third look hysteroscopy. The control group also underwent hysteroscopies at 4 weeks and 8 weeks, but no balloon dilatation was done. And surprisingly, they found that in the balloon group, the adhesion reformation rate was down to 20% as compared to 40% when no balloon dilatation was done. So these are all small tips and tricks where you could improve your results and prevent the recurrence of adhesions, especially in mild to moderate cases. Cornual adhesions, newly formed or reformed adhesions, balloon dilatation definitely works. Obviously, it cannot work in a dense fibrotic adhesions with total destruction of the cavity when nothing really is going to work for the patient. Another common question I am always asked is, very often I see fluid in the cavity. What should I do? Should I cancel? Should I go on? Should I do the transfers? So what is the available evidence for endometrial cavity fluid? The common causes, of course, we know PCO patients. Hydrosalpinx, one of the most obvious causes where we would just cancel the embryo transfer if it's inadvertently detected during stimulation. Although I hope that we always diagnose it before, at the time of the first consultation, and do a good lab clipping so there are no last minute hiccups for the patient. HRT, FET cycles. Now, this is one area which we really need to focus, because this particular group, when you use high dose estrogen and do HRT FETs, is where the high estrogen itself sometimes causes accumulation of endometrial fluid. Of course, previous pelvic or endometrial surgery, large ischemocele, cesarean section cases, chronic endometritis, another very important cause of endometrial cavity fluid. In 2015, Liu showed that yes, pregnancy rates were definitely lower. And he also clearly showed, which we knew for almost 2 decades, that if there is a hydrosalpinx, you straight away cancel the cycle and there is no question of doing an embryo transfer. Subsequently, Zhang in 2021 again showed that the presence of fluid before embryo transfer is often associated with implantation failure. But just to set the point straight, the same study showed that the pregnancy rate doesn't drop from 40% to 4% as with a hydrosalpinx if the fluid is of any other etiology, could be just excessive mucus, could be cervical fluid, could be endometrial secretions, or could be tubal fluids. The live birth rate, clinical pregnancy rate, biochemical pregnancy rate, and implantation rates significantly lower, but not too low. You can see from 56%, going down to 48% from 63 to 56. So there is a marginal, although statistically significant reduction in success rates, but you don't have to panic and go and cancel cycles because of the presence of endometrial cavity fluid. And this study concluded that all you need to do if there is a minimal fluid, you just do a TVS guided aspiration with a simple IUI catheter. Or if she is still for a transfer in the next cycle, you can do a gentle curettage of the uterus, which seems to be effective. This paper also mentioned some Chinese herbal medicines, but because those are not available to us, obviously, I don't want to put it here. And they said you can process ECF immediately, means remove it, and avoid postponing embryo transfer, which often has a lot of economic and psychological pressure on the infertile couple. So here, Gwen in 2023 did another very interesting study. A lot of you might have seen that during the stimulation phase, you saw fluid in the cavity. And on the day of embryo transfer, somehow the fluid had disappeared. And then there is the dilemma that should I cancel and do it next month, or should I go ahead with the transfer? You can easily go ahead. You can clearly see here, if the fluid is resolved, you have the same live birth rate as in patients who didn't have any fluid right from the outset. So you can see the live birth rates are maintained, and there is no need to panic if you see fluid during stimulation or during estrogen preparation. Once you start progesterone and she comes in for transfer, if the fluid has resolved, you can easily go ahead with embryo transfer without any decrease in the live birth rates. The most important point which I picked up from this study was that 5 patients decided to go ahead with embryo transfer despite having persistent endometrial cavity fluid, because they were the ones who kept having fluid month after month with different kinds of endometrial preparation. And yet 3 of them had live births just because they insisted that, okay, we are ready for the risk and please go ahead with embryo transfer. Most important point, which I told you earlier as well, that the incidence of ECF is higher in HRT cycles than in natural cycles. So if you find that this patient during stimulation did not have fluid, during the HRT preparation she has fluid, just cancel the cycle, go back to doing a natural cycle FET, and there is a very high probability that she will do well in that. So supraphysiologic estrogen supplementation may play a role in the development of transient ECF. Again, very important practical point that if the AP diameter of that fluid collection is less than 3.5 millimeters, there is no decrease in pregnancy rate. So you will still have your 35% pregnancy rate as compared to almost 0% if the AP diameter is more than 3.5. And the ones with more than 3.5 are where you need to investigate a stenomosil or a hydrosalpinx or severe chronic endometritis and so on, and find some other treatable cause of the endometrial cavity fluid. And that brings us to then chronic endometritis and its correlation with thin endometrium. And we know, of course, practically every aerobic and anaerobic bacteria can cause problems and chronic endometritis cases. The incidence ranges from 0.2 to 46%. 45% of infertile patients in this study in 2016 were found to have some form of chronic endometritis, especially those with recurrent implantation failure. And of course, tuberculosis, we know all the possible symptoms and how to diagnose and how to treat. But for the non-tubercular ones, you have to look out for endometrial micropolyposis. These are small protrusions which you often see when you do your hysteroscopy. And of course, the classic strawberry spots, hyperemic red endometrial areas with a white central point, again raising suspicion of chronic endometritis. Tuberculosis, of course, tubercles, caseous nodules, intrauterine adhesions, the shining star sign, the small shrunken cavity, history of tuberculosis and treatment in childhood or in the past, all would definitely point towards diagnosing tuberculosis. Treatment, simple doxycycline, 100 milligrams twice a day, 14 to 20 days. In fact, we now routinely give it to anyone with a thin endometrium before we embark on the embryo transfer cycle. Of course, for tubercular endometriosis, you would prefer to give the AKT. Second line treatment, cipro and metronidazole or ofloxacin and metronidazole. And papers have shown 2018 that patients who have given antibiotics and have cured chronic endometritis show a 4 times higher clinical pregnancy rate and a 6 times higher live birth rate than patients with persistent untreated chronic endometrial infection. So how do you go about treating your thin endometrium? So we've gone through all the various etiological factors. We've seen hysteroscopy as a perfect solution for surgical treatment. We've also treated with antibiotics the chronic endometritis, and we learned how to ignore or how to give attention to endometrial cavity fluid. And of course, estrogen revolutionized the treatment of the thin endometrium for us, and we've seen purification and better compounds available to us. We had the first micronized estradiol valerate in 2013, non-micronized hemihydrate in 2017, micronized estradiol hemihydrate in 2019. So how do I go about preparing a thin endometrium for transfer? Now, these are patients where you have to downregulate. You know, for all normal cycling patients with a normal endometrium, when you are doing a HRT FET cycle, there is no need to give a GnRH agonist depot in the luteal phase, because you know that in 14 days she's going to be ready. So the dominant follicle is unlikely to come. She's unlikely to have a premature LH surge. But for thin endometrium patients, please give the depot on day 21, because we know that she's going to take 25, 30, or even 35 days for the endometrium to be optimally ready. You can start with estradiol valerate or hemihydrate 6 to 12 milligrams daily, along with sildenafil 25 vaginally thrice a day and aspirin 75 or 150 daily. Day 14 or so, you would assess the endometrium. If you find that it's not optimal, it's just 6.5 or 7, I would change the brand, maybe switch valerate to hemihydrate. Maybe I would add a vaginal or a transdermal estradiol. I will, of course, increase the dose and step up to whatever is maximally permissible. And then I will again wait for about 7 days. On day 21, if I feel that the endometrium is still not right, you would then proceed with your intrauterine infusions, whatever you are a believer of, whether it is GCSF or PRP. And then maybe by day 25, day 30, if you have managed to push the endometrium even to 7, 7.5 or 8, you would initiate progesterone and plan your frozen embryo transfer. So as I showed you, if you expecting a normal endometrium, no need to give the agonist depot. You can see the percentage of patients who have a premature LH surge is just about 2%, which just doesn't justify giving 100 patients a depot preparation just for preparation of the endometrium. But for thin endometrium, please give it to each and every patient. Doses of estradiol. Of course, all of us are so used to now 12 milligrams a day as a starting dose for most of these patients of thin endometrium. But originally, remember, 6 milligrams is physiologically considered ideal. There is no clear benefit in, slowly stepping up from 1 mg to 2 mg to 4 mg to 8 mg and so on. Doses up to 16 milligrams have been used per day. And recently, I came across a paper which I'll show you shortly, where they even go up to 18 milligrams a day. They have also proposed unopposed estradiol for up to 9 weeks. Of course, these are very old papers from 2006 and so on. And we know that very high doses and unopposed for a very long time could increase various risks for the patients and are best avoided. So if at all you really want to mimic a natural endometrium in the best possible manner, very interesting study from 2022 that you give 4 milligrams a day for the first 1 week, then step up to 6 milligrams until transfer. Of course, it would be double of this for the thin endometrium. And apparently, compared to other step-ups or compared to what we normally do at a fixed dose start, endometrial thickness, clinical pregnancy rates, and live birth rates are the highest for this particular protocol. 7 days of just 2 milligrams BD and then 2 milligrams TD until embryo transfer. We keep hearing which is better, valerate is better, hemihydrate is better, and so on. Ingle in 2020 showed that clinical pregnancy rates were the same, although he found a significant difference in implantation and ongoing pregnancy rates, and found that maybe hemihydrate was a bit better than estradiol valerate. Subsequently, Banker in 21 showed that there was no major difference in clinical pregnancy rates, abortion rates, ectopic pregnancy, and live birth rates, showing non-inferiority. So both are equally effective in most patients, and it's your personal choice which molecule you would prefer to use. But I will shortly give you a small trick that I have found very useful in these patients of a thin endometrium, which brings us to how to avoid the first bypass effect. And that is where you have alternate methods of administration. For example, transdermal, where you get more steady state levels of E2 and you have higher ratios of E2, E1, which will benefit endometrial growth with the transdermal patch or the estrogel. Vaginal administration, Velasco showed in 2016, does give a higher concentration of estradiol at the end organ, and that is the endometrium. And that is why I will give you a secret tip. And what is the secret tip? That yes, you gave your 14 days of oral valerate or hemihydrate, 12 milligrams, 16 milligrams a day, and you're still finding that the endometrium is just about 6.5, 7, 7.5. Then just give her estradiol hemihydrate, like for example, Endofert H, that is what we give. 2 milligrams BID is usually sufficient for 2, 3, or even maximum of 5 days. more or less in 70 to 80% of patients, I have observed an increase in the thickness by 2 to 3 millimeters. Only where the endometrium is thin for unexplained functional or hormonal reasons. Of course, when you have Asherman's or chronic endometritis or tuberculosis, you cannot expect this increase. But for generally most of your patients, where you feel that, oh, in the stimulation cycle, she was at 8.5, and now in this HRT cycle, she's stuck at 7.5, to get that small boost of 1 to 2 or 3 millimeters, this works really well. In addition to the oral, just give 2 or 3 days of estradiol hemihydrate BD vaginally to these patients. What is the maximum you can go with unopposed estrogen or estradiol valerate without affecting the final outcome? And please try to not exceed 35 days of just estradiol. You can see here after that, you have an increase in the early pregnancy losses. Of course, I have had good ongoing pregnancies, even doing transfers on day 55 of estrogen when I'm finally happy with the endometrium. But those are sporadic one-off cases. Nothing in our field is 0% or 100%. So what we are trying to say is that if she is reasonably okay at 30 to 35 days of estrogen in terms of thickness and blood flows, you can easily proceed with progesterone. What about other treatment options? Because we keep getting flooded in IVF, it's one field of medicine. We have the maximum add-ons for everything in our practice compared to any other field of medicine. So we had this long list of HCGs, tamoxifens, L-arginine, sildenafil, and so on. What is the available evidence that these really work? So HCG injection, of course, there were some papers, 2013, 150 IU of HCG for 7 days, starting from day 8 of 8 milligrams of estradiol, which showed a benefit on the endometrial thickness. And then there were other papers which said that HCG did not, in fact, reduce pregnancy rates in some patients who had a normal endometrium. So these interventions don't really have much evidence. Tamoxifen, of course, we are all familiar, 25 milligrams of tamoxifen a day, day 3 to day 8, along with 1 milligram of 17-beta estradiol from day 5, as this study showed, clearly showed that tamoxifen cycles, you had much better outcomes, and the endometrial thickness was much better, whether it was the HRT group or the OI group, and statistically significant improvement in endometrial thickness with tamoxifen. Mid-luteal agonist, again a paper from 2008, where they gave triptorelin 0.1 milligram on the day of pickup, transfer, and day 3 after transfer, and again showed an improvement in the live birth rate from 5% to 31.6% in thin endometrium. Growth hormone, just as it works well on oocytes, maybe it also has a mitogenic effect on endometrial cells. And this study showed, random study here, clinical pregnancy rates with the addition of growth hormone in thin endometrium going up from 19% to about 42.5%. Aspirin, of course, was one of the oldest and one of our favorites still today. Although you would be surprised or rather shocked that we don't really have evidence whether it works in a thin endometrium patient. So we are not expecting an improvement in endometrial thickness with aspirin, but I'm sure all of us agree that there definitely is a benefit, not only for countering the side effects of high dose estrogen, but also maybe improving a little bit of the pregnancy outcomes. So we had these huge Canadian guidelines in 2019, which practically disagreed with every adjuvant. So it said aspirin is useless, vitamin E useless, pentoxifyl useless, GCSF useless, nothing works. But when we go into a detailed analysis of the guidelines, most of them are based on just 1 or 2 really well-controlled RCTs, and the sample sizes are quite small. So subsequently, in the last 4 years, we have had a lot of research on all these add-ons, and a lot of them seem to be convincing for daily use. For example, you can see here, insufficient evidence for sildenafil, insufficient evidence for pentoxifylline. But in 2020, you can see this huge paper, more than 10,000 women, use of sildenafil citrate in a hormone replacement cycle treatment. 40% versus 36%. Now you may feel it's just 4% increase, but 4% is a huge increase for anything in vitro fertilization. L-arginine, again, we know it is most of these adjuvants and add-ons don't have any major or minor side effects, which is why it's quite safe and easy to use. Again, L-arginine, also a lot of papers showing that it does benefit a thin endometrium. Scratching, of course, there were a lot of opponents to scratching, a lot of proponents for scratching. This study came out, big RCT in 2021, and they showed that 4.6% again more live births were observed in the scratch group. Now, each of these are highly debatable, and I'm sure there'll be a lot of people who think that they don't work. A lot of people think they work. Finally, it's your own experience. What you feel works for you, please continue doing it. Huge attention now being given to the use of probiotics. Just we have probiotics for good gut health. We also now have specific probiotics for endometrium, specific probiotics for the sperm, and maybe by restoring the right balance of lactobacillus in the endometrium, we might be able to improve pregnancy rates in these cases, especially those associated with chronic endometritis. And this year at ESHRE in Amsterdam, we had almost half a day session only on microbiota and the use of probiotics for improving endometrial receptivity. And finally, of course, you have your wonderful intrauterine infusions. And we know that one of the main attributable causes of a thin endometrium could be the malfunctioning of endometrial stem or progenitor cells in an incompetent thin endometrium. And therefore, cell-based therapy, such as using stem cells or mesenchymal or umbilical or amniotic membrane and so on, could give us a new platform for treating a thin endometrium. Of course, there's a lot of research going on here, and I'm going to leave you for some interesting thoughts, especially for the endoscopic surgeons. How did it all start? Of course, that wonderful case report we had of 4 patients by Gleicher and Berard in 2011. 4, if you look at the pictures, they had the worst possible endometrium you can think of, with fluid in the cavity and everything. And after GCSF infusion, they established pregnancies in all 4 patients. And that is how this wonderful story of GCSF began. And then we had so many case studies after that, some showing a difference in implantation rate, some showing higher pregnancy rate, some showing higher endometrial thickness, significant improvement clinical pregnancy rate, and so on. We had the American Journal 2017 in a large meta-analysis showing endometrial thickness, GCSF in favor of GCSF, clinical pregnancy rates in favor of GCSF, embryo implantation rate in favor of doing intrauterine GCSF, cycle cancellation rates, again lower with intrauterine GCSF. And then you had the European Journal in the same year, 2017, again do a large meta-analysis, and they found contrary results, that there is very low evidence to support the use of GCSF in thin endometrium patients. And then you had all these other evidences which have been published over the years. Again, you can see here, did not alter endometrial thickness, clinical pregnancy rate, there was no benefit, increased thickness, but no increase in clinical pregnancy rates, and so on. And so we still don't know the real status of GCSF. But then we had a new kid on the block, and that is our platelet-rich plasma. So again, the Canadian guidelines clearly saying that there is no evidence in favor of intrauterine GCSF. So now we have platelet-rich plasma, which seems to be more promising. And I'm sure most of us, 80 to 90% of our using is in our thin endometrium patients, because we really have nothing else to offer. And we also somewhere believe that it has helped a few or quite a few or a lot of patients with thin endometrium who had previously failed IVF cycles to conceive. But how exactly to go about it? And this was one of the first meta-analysis showing almost a doubling, relative risk of 1.8, 1.8 to almost 2, increase in the clinical pregnancy implantation rates, and so on. Increased pregnancy rate, again, you can see here in favor of PRP in a large meta-analysis. Higher clinical pregnancy rate in thin endometrium and RIF cases. Almost a doubling from 20% to 44% with the PRP group as compared to a control group in this small study of 30 patients for thin endometrium. But some more, this is required for this technique, that should we just do intrauterine instillation, or do we need to do something better if we really need a good proliferation of the endometrium? So in 2020, we had this study by Minu Agarwal and Lilo Mettler. Injection of PRP via hysteroscopy into the endomyometrial junction improves endometrial thickness and vascularity. And subsequently, we have done quite a few cases, and it seems to be giving better results than just doing intrauterine PRP infusion. So a total of 4 ml of PRP injected with a ovum pickup needle, all 4 walls, 1 ml in each wall. And you have to keep the beveled edge of the ovum pickup needle in such a way so that you don't have immediate leakage of the PRP. And you see the nice wheel or the nice bleb being created when you inject it exactly at the endometrial myometrial junction. So timing, of course, you give the depot, as I told you. You do hysteroscopic PRP instillation in the luteal phase, wait for menses, immediately estradiol valorate, and then plan your embryo transfer as usual. So it has to be done in obviously the late luteal phase of the previous cycle, because you can't do it during the HRT FET cycle because of the invasive nature and the disruption of the endometrium that you would cause. And they found an endometrium of 7 or more in 24 of these 32 patients who previously had very thin endometrium. 12 of the 24 patients conceived, 10 had a clinical pregnancy with visualization of cardiac activity at 6 weeks, and 2 had a biochemical pregnancy. So very promising results in these patients. In fact, the first patient I did it was a doctor herself, and she had failed 3 IVFs with a very thin endometrium of 5.5 to 6, and we thought she was an ideal candidate. So we did a subendometrial PRP in the luteal phase. And then what I had heard at ESHRE last year was that you should combine it with intrauterine infusions. So in the luteal phase, we did subendometrial PRP. Then after she was on estrogen, high dose estrogen, day 7, day 12, and then day 15, we did intrauterine infusions of PRP. I thought she has failed so many cycles, so there's no harm in putting 3 embryos. As most of you must have guessed, she ended up with a triplet pregnancy. So it was seeing is believing. So finally, you have to do it and decide which is the best candidate for this type of an intervention, which is not really dangerous, doesn't have too much of side effects, and there's no harm because you're using autologous PRP. Again, another study, 2023, whether you should do just infusion or injectable. Now, this was a slightly different study here because they do the endometrial injection during the cycle of transfer and not in the previous cycle. So you can see here in the infusion group, 2 milligram of estradiol, that is 6 milligrams per day from day 2 as usual. After 7 days, they stepped up to 6 tablets daily. First, I intrauterine infusion of PRP on day 7. After 2 to 3 days, endometrium was reevaluated. They stepped up to further 9 tablets daily. Second PRP infusion on day 12, and third infusion the day they started progesterone. So around day 15 or day 16, as I mentioned earlier. The injection group preparation was in the same way, but on the 7th day, they did a single subendometrial injection of PRP, this time guided by ultrasound. So there is no hysteroscopy done, so there is no disruption of the endometrium. You simply go through the myometrium and inject under the endometrium. And it was done again using a transvaginal probe with a double lumen oocyte recovery system, delivering about 2 ml of PRP in the anterior wall and 2 ml into the posterior wall. And clearly the injectable PRP group had a higher pregnancy rate as per this study. You can see here pregnancy after treatment much higher in the injectable group as compared to where just infusion of PRP was done. So of course, there'll be so many variables. No 2 cases will be the same. And finally, it'll after 20 or 30 cases, you might develop enough experience to know that who will benefit with just intrauterine and where you should be doing the hysteroscopic PRP. So of course, infusion is easier. Injectable is slightly invasive. Ultrasound can be done in the transfer cycle, which you cannot do with hysteroscopy, and ultrasound guided activation, according to this study, does seem to be very promising for these patients. What about chronic endometritis? Just doing intrauterine PRP, we just keep talking about thin endometrium, but thin endometrium as a consequence of chronic endometritis, again, a nice study from 2024 showing that you can increase the number of live births by doing intrauterine subendometrial injections of PRP in this difficult group of chronic endometritis patients. New hope on the horizon, and this is what all endoscopic, hysteroscopic surgeons can easily do. In fact, we were just in the process of setting it up because you just need to tie up with a science institute who can give you a mesenchymal umbilical cord stem cells on collagen scaffolds. So that's all you need for them to do, and I'll show you how it is to be done. So 20 million umbilical cord mesenchymal stem cells loaded onto a collagen scaffold, transplant into the uterine cavity in 2 consecutive menstrual cycles. Then they assessed with a hysteroscopy how better the cavity was, how on ultrasound the thickness was better. All these were compared. And it's easy to do. You can see here umbilical cord mesenchymal stem cells loaded onto these collagen scaffolds, incubated for a short time, then wrapped onto a Foley's catheter and inserted and transplanted into the uterine cavity. So you can see here, this is how it is done. Collagen scaffolds are rinsed with a suspension of the stem cells. These are then incubated for an hour before transplantation, and any research scientist in molecular biology are used to doing this all the time. So if you just have to collaborate with them to get your supply. Hysteroscopic confirmation, of course, first that you have completely cleared the cavity. Then you spread these scaffolds onto a Foley catheter bulb. Balloon is filled with 3 ml of saline to assist the scaffold in attaching to the inner wall of the cavity. Confirm that the scaffold is properly placed on ultrasound. Leave the balloon in place for 3 days and cover the patient with antibiotics. And you can see the hysteroscopy pictures before and after. Most of the after seems to be much better cavity-wise than what they were before the treatment. And even ultrasound, there was a significant increase from 4.5 mm to almost 6.6 mm post-treatment with this. But what about pregnancy rates? Of course, 4 of the 17 patients became pregnant, of which 3 had live births, 1 had a miscarriage. Remember that a lot of them did not reach transfer. So all 17 did not reach transfer. So the pregnancy rate cannot be calculated as 4 of 17. They had to be because the endometrium just didn't budge. And if you remove those patients, the final pregnancy rate of 24% and live birth rate of 18% was highly acceptable in this very difficult group of thin endometrium patients. So to conclude, what should be our focus for all future therapies? Remember that in a thin endometrium is usually because of impaired EGF, PTN, and tweak signaling pathways. Also overactive activation of the SEMA3B pathway. Increased cellular senescence and collagen over deposition with decreased gene expression related to cell proliferation. So all interventions should now be targeted towards promoting proliferation of stromal cells, and that is where subendometrial PRP, collagen scaffolds with mesenchymal stem cells and so on sound very promising for the future. Anti-senescence and anti-collagen over-deposition molecules which can be deposited locally in the endometrium. So with that, ladies and gentlemen, we come to the end of this very difficult topic, and that's the first time I'm talking on a thin endometrium. So I hope that it was useful to you. So thank you once again for attending in such large numbers. Thank you to Dr. Aruna. Thank you, team Intas. Thank you, Dr. Vishal, Dr. Lay for organizing, and wishing all of you a lovely weekend. Thank you so much.
Yes, sir. So you thank you for the wonderful presentation. You dealt the whole of thin endometrium, covering from adjuvants to umbilical cord stem cell therapy. So it was fantastic. We have lots of questions here. So let me take it up. So for endometrial priming in FET cycles, what starting dose of oral estradiol hemihydrate therapy do you suggest?
You can directly start with 12 milligrams for the thin endometrium group, or you can give, say, 6 to 8 milligrams for the first 1 week and then step up to 12 if you don't want to directly give a very high dose. You could also give a combination. So you could give, say, 12 orally, and you could give maybe some extra in the form of estrogel or vaginal hemihydrate to try and, reach the endometrium in more higher proportion. So these are various combinations you could use, but you can safely directly start with 12 milligrams as most of us tend to do.
What is the maximum dosage of estradiol in any formulation you want to give for a patient?
I usually don't go about 12. I'm scared, although the published literature says you can go to 16, 18. You saw that paper where they go to 9 tablets and 12 tablets and so on. So I'm not in favor of that, because I've heard of a case of thromboembolism, not in my practice, but somewhere else. So I would definitely be a little scared. And you also have to counter it with 75 or 150 of aspirin and be careful with these patients. So that's why a combination works better. When you use a combination of oral and vaginal, you more or less try to reduce, the chances of having any major thromboembolic complications and so on.
Yes, sir. Out of the curiosity, is there any benefit of using for a patient who has already had a thromboembolism, like a cardiac event or a cortical venous thrombosis? What is the preferred method or route of estradiol you would suggest?
I would strictly do a natural cycle FET. I wouldn't want to take a risk with her. So I think natural cycle is the best. If at all you have to give medicated, then just 6 milligrams a day with enough of aspirin, maybe heparin, and make sure that you don't have any kind of adverse outcome for her. And don't give very prolonged. Within 10 days of estrogen, start the progesterone and do your embryo transfer. So for normal endometrium with all those things, it's fine. Thin endometrium, again, it's a dilemma that how I to go in such a patient.
Do these patients we can avoid oral and give them estradiol gel applications and vaginal route, because it bypasses the first pass
Yeah,
metabolism?
that's a very good idea as well, that you can just use transdermal and vaginal and just avoid oral totally. But these are rare
Because
patients. We don't see them too often.
yeah. But nowadays they're postponing the pregnancy too much that at 45 with after a cardiac event they come to us, and we are also scared, as you told, sir. So actually there is a question that what is your view regarding use of estradiol hemihydrate vaginally for increasing endometrial thickness?
I already showed that, na, is the secret tip slide.
It is a very nice preparation for vaginal. I think it gets dissolved. It's very small. The patients are also very happy.
Especially endofert, and it gets absorbed. It doesn't come out the pieces and all that. So that's why it's our preferred brand.
Yeah, but the sildenafil, whatever combination we give, the patient tells that the entire sildenafil comes out as a, and they take it the next day. I think they are happy with the Endofort H that they introduce. What is
I
new
think we
to treat?
overuse sildenafil a bit, but now it's so ingrained into all of us, that it's difficult to now reduce or stop using it. But let's see, time will tell, because the literature is all conflicting. Yes, no, yes, no, yes, no. So we don't know.
Yes. What is new to treat thin endometrium in case of natural or an IUI cycle? I think you have covered
IUI, so of
everything.
course, if it's clomiphene, that's the commonest cause of a thin endometrium. Even in letrozole cycles, I have seen even when the follicle becomes 19, 20, on the day of trigger, the endometrium usually is just 7 mm or 7.5. But the minute you give the trigger and she comes back on IUI day, in letrozole cycles, they usually reach 9, 10, 11 mm. Clomiphene, of course, you can't do much. There are studies that you can give the agonist trigger instead of an HCG trigger if you find asynchrony between follicular size and endometrial thickness in a clomiphene cycle, and you don't want to cancel, then that is one trick that you can do. But generally, if you're on clomiphene, the endometrium is 5 mm, 6 mm, I would just cancel. And as it is, we hardly use clomiphene nowadays. It's always letrozole as the first choice. So if at all it's clomiphene related, then fine. I think the person who's asking is because they might say that in IUI, can we add estrogen along, in the follicular phase? So that is where I need to tell that if it's clomiphene induced anti-estrogenic effect, exogenous estradiol will not work. If it's any other cycle, there is a new paper now, because we kept saying that exogenous estradiol is useless, but that was always for clomiphene cycles. We forgot that point. So in other cycles, maybe a little bit of estradiol could be added, but we are not sure of the benefit, because there's just one paper now that says that you should add estradiol in an IUI cycle in the follicular phase if the endometrium is not too good. So it's debatable.
Yes. What we felt in our practice is not all the patients we are there in IUI cycles when the follicle is 19 to 20. If the repeated thin endometrium is coming, sometimes when we check the estradiol levels for the patient, the follicle is so bad that the poor ovarian reserve patients that it is not producing enough estradiol, and it is just a functional cyst. Sometimes it's only 50, 40 estradiol, and those patients, I think it is a follicular problem and not an endometrial problem. I think differentiating between follicular endometrial problem also plays a little bit of role. Anyway, as you told, nowadays in letrozole cycles, if the thin endometrium is there, there is a point in adding estradiol after the follicle is
Maybe,
at
I'm
least
not sure, but I am,
70.
in my experience, the minute I give the trigger on the day of IUI, most of them cross 8 mm, so I'm not really worried about them. A good point you brought about poor responders, because now they are further categorizing poor responders into different types, and the dysfunctional ones are where they have recruitment of the dominant follicle in the luteal phase of the previous cycle. And those are the ones where then your folliculogenesis is not too
Yeah.
good. So whenever you're doing IUI, it's very good you brought up this point. Whenever you do IUI in a poor responder, you must give pre-treatment. And I don't mean ocipil pre-treatment. You should use estradiol valerate from day 25 of the preceding cycle, so that you don't have this premature selection of the dominant follicle, and you don't have premature LH surge. They've also shown that this group of patients is the one who is prone to premature LH surge and luteinization of the follicles. Of course, people like us, we give antagonist even in IUI. So we may be not seeing that. But generally, if you're not using an antagonist, you will very often find LUF, luteinized unruptured follicle in poor responders, because of their aberrant folliculogenesis, which begins in the luteal phase of the previous cycle. So the only cure for that is to give estradiol pre-treatment even in IUI for all patients.
So you give it from day 18 till the day of,
Day 25. Till they come to you, then they
or
continue
just
day
10
2,
days and
3 or
stop
4
it,
of
sir.
the menses. No, not 10 days. They have to continue during menses till they come to you. Then on day 2, day 3, once you begin your day 3 letrozole or something, that is the time you can stop
Yes.
the estrogen.
Fantastic. So there is another question, is in your routine practice, for whom you would advise modified natural cycle rather than HRT for FET
We are trying to
preparation?
do more and more natural cycles, because I am a strong believer now, because it works like magic when there are patients with previous multiple IVF failures with HRT, FET cycles. So, we always keep blaming the embryology, we keep blaming the drugs, we say short protocol, long protocol, FSH, HMG, M2s, quality of embryos, and so on. But we forget this point. So it's very important to remember this exactly what you just said right now. So
Yes. What are the add-ons that you use in your practice for thin endometrium? And whether you use GCSF subcutaneous or intrauterine?
no, I use most of the things I showed, because I only talk what
This was the question from one of
So I
the.
give high dose estrogen, I give sildenafil, I give L-arginine, then I add vaginal endofert, then I do intrauterine PRPs. We used to do GSF, but we stopped doing that. Scratching occasionally, if I feel that the patient needs it, we do it on the day of egg retrieval, just a simple, 4 strokes on the 4 walls. That's it. So most of the things we do, although I know there'll be enough number of people who will say it is all useless and doesn't work, but it's 30 years of work and we feel that okay, something somewhere works. And if it's
Yes.
harmless, what's the harm in it?
As you rightly started with the talk that it is a desperate situation that we have embryo and that endometrium is still thin, what to do? So, out of curiosity, is there any use of sitagliptin for a patient? Because there are some articles which has told that the sitagliptin improves the implantation for the patients and with recurrent thin endometrium and implantation failure.
No,
Any?
no, I don't know. I
No.
have not used it.
Okay. GCSF, you prefer to use subcutaneous or intrauterine, sir?
Intrauterine.
And when do you use it?
Intrauterine only.
Intrauterine.
Same as PRP. Na? The day 14, day 20, if the endometrium is not adequate, then we do intrauterine GCSF. We used to do. Last 8-10 years, I think it's only PRP now. First, we started with a commercially available PRP, which was supposed to have, a fixed amount of growth factors. So there was no patient-to-patient variation, which you can see with autologous PRP. But then gradually we now shifted to the activated PRP kits, which are available for autologous blood, and we find similar results. So now we stick to that.
Yes, sir. There is another question. Post-hysteroscopic anti-adhesive gel do you use, sir? What is your personal experience regarding balloon?
Oh, I'm very happy with balloon. So I don't put IUCDs and copper Ts. Whenever we have done a reasonably amount of dissection, it's always the balloon, 48 to 72 hours. Usually I would do a relook hysteroscopy after 4 to 6 weeks, because again, there will be some flimsy adhesions which may need removal. Second time, I may or may not put a balloon. And then of course, she'll be on estrogen priming as well. So that's how we would take them forward. But balloon is first choice for sure.
Balloon for, you leave the balloon for how many days, sir?
3 days, 72 hours.
3 days. So for all the patients, is the balloon being inflated? Because some patients, the balloon doesn't go well.
They
We
cut off
saw
the
the
tip. You have to cut off the tip of the catheter and then
then
you go and touch the fundus. Usually you are able to do it, and we confirm with ultrasound the placement. Sometimes you have just put it in the cervical canal or something, so you have to just do an ultrasound, make sure that it's touching the fundal endometrium, the balloon, and then come out.
There is one question that persistent free fluid in spite of antibiotics. It's a free fluid or endometrial fluid? She has asked it as free fluid. I think she's mentioning endometrial fluid. Natural cycle APT, no.
If there's no hydrosalpinx, if there's nothing other big isthmocele or any other reason or Asherman's or pockets of fluid, then you just have to do a simple aspiration, maybe 2 days before embryo transfer. And if on the day of transfer, you see there is some little fluid left, if it is less than 3.5 mm, you can just go ahead with doing a transfer. And I've personally had a couple of pregnancies doing that. So we don't always say that, oh, fluid means just cancel transfer. It doesn't work like that. And I showed you the supporting evidence as well. So if the fluid is minimal, you don't really need to cancel a cycle. Persistent fluid, you have to do a hysteroscopy, you have to rule out hydrosalpinx, you have to rule out treat chronic endometritis, give her a course of doxycycline, and do an aspiration maybe 1 or 2 or even 3 times before you do the embryo transfer, but you can go ahead with the embryo transfer.
Have you started empirical AKT for any of the patients because of persistent fluid?
We don't see too much of tuberculosis our side. So when I used to work in North India 25 years ago, we used to have a lot of genital tuberculosis cases. Means it used to be as high as 10%, right? But fortunately in Mumbai, we don't see too much of genital tuberculosis. And empirical AKT is out of question. Only if my hysteroscopic surgeon says that it looks like obvious COX, then we have to give a proper AKT and notify the authorities. And now you just can't give empirical just like that.
Yes, because of the regulations, and the drug resistance is one of the biggest problem that we are facing. So there is a question. I think sir has already answered this question that intrauterine GCSF, whether we can use, what is the time that we use? Sir is almost using PRP for many of the patients. You can just tell maybe what when is the time that you put PRP for your patients, sir? How many sittings?
So if it's a mild case, then it's just one. Suppose she's at 7.5 mm, then just one PRP is enough, usually day 18 or day 20 or anytime at that. And they are down regulated, so we are not very hard and fast about the day of the cycle. That's not important. If she is say anything around 6 to 7, then we would have scheduled her for 3 intrauterine PRPs, usually day 10, maybe day 13 or 14, and then day 18, 19. Again, down regulated, so it's not hard and fast. And if it is severe, less than 5 or 6 mm with at least 1 or 2 previous IVF failures with good quality embryos, then I do the subendometrial in the luteal phase, hysteroscopic injection, because I'm still not comfortable with ultrasound guided injection. And then we do the 3 intrauterine ones. So it is hysteroscopic, luteal phase, 3 intrauterine after down regulation on day 10, 15, 20, whatever, and then do the embryo transfer.
It's very nice. So do you do fresh or frozen, sir? PRP. Everything is fresh, or you do freeze
Fresh.
the sample? And
No. We prepare it on the day of the procedure. The blood is collected on the same day.
okay.
For autologous,
Because
patients have to collect blood,
in
do
some
the
centers
actual.
they freeze do fresh once, and 2 times they do freezing, because the first time
We
only
keep
they
up-
collect the sample.
No.
PRP.
No. Patients don't mind. It's okay. Collecting.
Yes, sir. We had also published an article from 112 patients of subendometrial stem cells, bone marrow mobilized stem cells in the X-ray, and it was well appreciated. So it was
Oh, yeah. It was
a very
one-
nice topic
yes.
of interest for me too. So it was a fantastic. Yes, sir. We met
No,
you there,
I'm
and
quite
we
excited about it.
Yes.
Yes.
Yes,
Right.
sir. So thanks a lot for your presentation. I think there are lots of questions still, but I think we have covered major, and your talk entirely covered everything. So fantastic evening, sir. Thank
Thank
you.
you so much. Thank you, everybody. Thank you.
Thank you, sir. Thank you, Dr. Jatin Shah, sir, and Dr. Arun Ashok, madam, for giving a valuable time.
Thank you.
Thank you.